Welcome everyone to the Jumpstart Health Investors webinar. I have Emily Evans with me today to talk through understanding healthcare regulation as we are in the run-up to the election in 40 or so days away. And so exciting and wild times in politics. But what's really interesting is that health policy, as we'll see with Emily, we can really try to understand that independent of the presidential politics, because there's a lot of complexity. It takes a long time to implement. Of course, healthcare is $3.5 trillion a year. About half of that is paid for directly by the government, and all of it is highly regulated. I've known Emily Evans for a long time. She has been an elected official. She's been an investment banker. She currently works at a firm called JHI Health Pro. Emily, thanks for doing this. Really appreciate it.
Oh, thanks for having me, Vic. It's fun to be here. Glad to be on your platform.
yeah, exactly. Good. So Emily, maybe just give a quick summary of your background, a little more detail than I gave, and also how JHI works in understanding all the complexity around healthcare policy.
Sure. So my background is like a ridiculously eclectic resume. So I was on Wall Street. I started my career on Wall Street in finance, specifically municipal finance, and which naturally means a lot of financing of healthcare. And financing of anything healthcare requires a deep understanding of the regulations and the law and the mechanisms by which things get paid for. I did that for quite a number of years, and then I was at J.C. Bradford, which of course is the hometown investment bank, which was acquired, and my children were young, so I thought, oh, just go home and play tennis, and I'll work.
How long did that last?
18 months.
Yeah.
And I got called into a big some big land use debate in my neighborhood, and that ended up raising my profile. I got recruited for office. I served for about 9 years under 2 mayors, and have stayed pretty politically active. But the value of being in office gives you a really great perspective on how law gets made, what the pressures are, what the decision-making process, which is surprisingly similar no matter what level of government you're at, whether it's state, federal, local. You have very, very similar pressures, and did that for about 9 years, and my kids are big, so I thought I'll go back and try and resurrect my career. So since about 2013, I've been really working at the intersection of Wall Street and public policy. And what I try and do is educate investors on policy and regulation in a way that is actionable. Who needs another white paper, on what might happen, but gives them a good sense of where things stand today and what those pressures and trends are that move it in a different direction. And I inform that with a lot of time in politics, a lot of time in government, and knowing all the personalities involved, and understanding how they speak. What most people, when they're reading, whether it's general media like the New York Times or the Wall Street Journal, or they're reading political media like Politico, or they're watching CNN, they're getting a highly filtered view of information, and that isn't to say biased or not. That is highly filtered for consumption by a mass audience, which is very, very different. So the what is happening in the legislative and legal processes can be miles apart from what the perception is within the general readership. And in there is a ton of opportunity, because what you think is going on, and this has never been more true than it is right now. I watch press conferences, and then I read the reports of the press conference, and I thought, that's not what I heard. But that's not a political statement. That really is kind of a
Yeah. So I have a bunch of questions. I want to, just as a housekeeping matter, we will have time at the end for questions from the audience, but also feel free to use the Q&A button or the chat. I'll try to monitor both. So as Emily mentions things, or if you want to follow up on something that I have a question on, feel free to chime in via the chat or the QA, and then I'll try to hit on those as we go, and then we'll have time at the end as well. So Emily, one of the things that you really have taught me over the last few years is that there's a pace and a process to how laws get made, and then that filters down into the bureaucracy and the rulemaking. And that is really helpful, I think, for investors to begin to understand. And so I asked you to prepare a couple of slides. Maybe you could talk through that, either just verbally or show some slides, whatever is easiest.
Okay, I'm gonna, let's see.
You should be able to present your screen, I think.
I think hopefully I just shared it. It's, let's see, how about right here? Okay.
Yes, I think that's working.
Okay, good. So in this, this is civics 101, but we don't teach civics anymore. So, and a lot of people have forgotten this, in large part because when it's presented, nobody exactly explains where it is in this continuum, but Congress passes a law, it's a bill on Capitol Hill, as the tune goes. Congress, and that, those bills have to be introduced, they have to be agreed to by both sides of the House, both sides of the Hill, and they pass a law. And that doesn't happen a lot lately, because their gridlock for sure is a factor, but another factor is that the interest, the things that are interesting to legislators, people who go to the Hill, have departed in a lot of ways from the things that need to be done. So you have a lot of focus, for example, on the Green New Deal, which, regardless of its merits, that means that as the health system has evolved and changed, you've got embalmed basically in amber the Medicare law, Medicaid law from in some cases the 60s. But Congress, and you'll understand why I'm saying that in a minute, but Congress passes a law, and from there the agencies develop the regulations. And they also they develop, they issue them, they issue the regulations. There's usually 60 days for comment, and then they finalize them. What makes regulations interesting, and a lot of them are done on an annual basis. Annually, they review the physician fee service for Medicare, for example. And those, as they are, when the agency, in this case, we're interested in the Centers for Medicare and Medicaid, or the FDA, when they issue those, that's how they speak. That's how they speak to their priorities and what they plan to do. We have two constitutional concepts that control a lot of what is done in the rulemaking. The first is notice, proper notice. Courts and the Constitution don't like agencies to jump out of the bushes and suddenly upend things. And I know people think happens all the time. It happens all the time because people don't religiously read the regulations to know what's coming down the pike. But proper.
So let's just touch on that. So as an investor, particularly investor in private markets, you have significant notice. You have several years, months, quarters, years.
Yeah.
Before something changes, and it is hard to digest, but it's in the public reports, publicly available reports.
Yeah, it's totally there. And a great example of that is site neutral policies.
Yeah.
The 3 years ago, 3 years ago, CMS signals knee replacements should be done outpatient. It takes them 2 years to actually finalize that. But you couldn't get, if you're a Medicare patient, you couldn't get your knee replaced except as an inpatient stay. And even though, it's pretty well established that for the right patient, an ambulatory surgery center even would be fine. So they signal that, that's coming down the pike. And they say things like, we considered removing total knee replacements from the inpatient only list, but declined to do it this time. We'd like to hear public comment on whether we should. That's a great example of where they don't.
That's a flag that they are likely to do that in a future issue.
Right. We call it a trial balloon.
Yeah, right.
Send it up the flagpole and see who salutes. And that happens all the time. What has been super unique about the last few years, Vic, is the speed at which that has happened.
Mm-hmm.
We under
and the speed, and also in healthcare, the breadth.
And the breadth, yeah. We can get into that in a minute, but the process of proposing change, hearing from the public, and then finalizing change, that does happen. It happens on a regular schedule, so you can sort of feel how the temperature changes and who is objecting, and what they embrace and what they back off of, and things like that. Once those regulations are developed, the final piece of it is the individual areas within that agency will issue specific guidance. The departments will alert and they'll send out these sub-regulatory guidance documents to the stakeholders, and you'll get I get regular emails from them, and those are things that are operational in nature. Here's how you should fill out your form, and and sometimes they can be a big deal, but they're more directed at the operations. So the real meat of the matter is in developing the regulations.
And what's interesting is that there doesn't have to be a law passed for the regulation to be changed. Like the knee decision that you were talking about, there was not a congressional law related to that, as far as I know. They changed the policy underneath the existing law.
Well, a lot of the law, unfortunately not all of it. And here, two examples. Telehealth. The telehealth law was written in a way that only Congress can change what we call the originating site. So when you call that doc, you have to do it from an institutional setting, which sort of defeats the purpose of telehealth, right? And clearly designed for a rural environment. You're at a SNF, or you're at a psych hospital or whatever. That is actually in the law, and the only way that's going to change is if the law changes. Now, take another example, the Part B drugs. Those are the drugs that, cancer drugs, typically you go to the outpatient clinic and you do infusion therapy. The law doesn't say that you have to pay average sales price plus 6%. That's not in the law at all. It says that CMS needed to study it, and come up with the right approach. Came up with ASP plus 6%, I don't know, 20 years ago, and it's stuck with that, even though drug prices have gone crazy. So, there are places where the law really has to change. Then there are places where the regulations have a ton of latitude. It
depends on how the law was drafted and passed, as to how much latitude the agency has.
Right, exactly. And also it depends on how creative the lawyers are willing to get. So as you and I talked about yesterday, you have this telehealth law, and that telehealth law says, you got to call from an originating institutional site. You have to be living in a rural community, and you have to do it via video conferencing like we're doing now. So you can't do it by phone. That's like I said, embalmed in the law. So what the creative lawyers at CMS have been doing is they created this new class of service called communication technology-based services.
Yeah, it's not telehealth.
It's not telehealth, but it sure looks a lot like it.
Right.
And it sounds a lot like it. And so these are things that are auxiliary to the practice of medicine. So a virtual check-in. You want to just check on that patient that that you saw 2 weeks ago, or now as the law is changing in the post-pandemic period, you're actually non-physicians and non-physician practitioners are going to be able to conduct E&M visits via this communication-based technology.
So even if the Senate and House don't pass anything, there still can be, now it's guarded within these guidelines of what the law says, but there can be a decent amount of change based on the president and the executive branch, and then filtering down through the agencies.
Yeah. Oh, yeah. Because they have the ability to, like I said, creative lawyers can come up with creative solutions, and very, very frequently, if you need an excuse, you have to change the law is a great excuse. But there's also these regulatory pathways where you really think really hard about it. And you come up with solutions like communication technology-based services that's not actually telehealth. And what this administration has done has been very, very aggressive on the executive orders as far as health goes. Because to get up to the Hill, convince them even modest changes raises the whole specter of the Affordable Care Act, which just sits like a big giant boulder.
It's like a block or something.
Yeah.
Right? But I think the Obama administration, and then it has been continued by the Trump administration, maybe accelerated. I think President Obama started with the executive orders, and then the Trump administration has sort of grabbed that and continued. Would you say?
And they have, been emboldened by the Trump administration by certain court decisions. There's, since the late 1986, there's been the courts have said, the shorthand for this is Chevron deference. The courts have said, if Congress said no to it, then you can't do it. But if it's reasonable interpretation of Congress's law, meaning they didn't say no, but they didn't say yes, then, and it's reasonable, then you can do it. And so they've taken that and run with it. And that's why you're seeing so much come through executive order on drug prices, on telehealth, on rural health, you name it. So
yeah. So talk about JHI. Maybe just how you work with me at Jumpstart, or how you work with investors in general. There are, it's publicly available, but it's pretty dense reading.
Well, and I would argue
by helping me understand it from a more English or business point of view, so that I can invest. Is that fair?
Right, and I would argue that it's not just its density, and this is going to sound really self-serving, but it's also, you can't read and understand that stuff unless you understand the political and regulatory context in which it operates, and the goals of the people that are proposing and sponsoring those changes.
Yeah, like they're sending smoke signals somehow that I can't see through the language, unless you know all the players and the secret code they're using. Even though I could read it, there's a lot of complexity like underneath the page that you see that it's hard for me to interpret.
Right, exactly. And a good example of that is during the COVID task force in the White House, Debbie Birx is talking about, fighting disease spread.
Just quickly explain who Debbie Birx is, or what the.
Deborah Birx is on the coronavirus task force at the White House. Ambassador Birx, she is really been worked very hard in AIDS and Ebola, so she's got a real good infectious disease background. But when she's standing in front of the microphones and she's talking about, controlling the disease spread, she says state and local government are going to have to partner with community groups. Well, I listen to that, and what she's telling me is that there's a lot of spread in immigrant and poverty communities, and these local governments need to get involved with those communities. That's not what she said, but
that's what she was signaling.
Right.
So if you have been, it's just like anything. If you're in the VC business, there are shortcuts and acronyms and things that are quickly conveyed that not everyone would understand, even though it's in English. And it's the same, even more so in politics and in healthcare policy.
Right, and we like to kind of we don't like to go up the middle when we talk about things, because then people start shooting at you. So you kind of, move around to the side. So,
Yeah.
So back to JHI. The idea was originally born out of working with public equity investors, who would wake up one morning and discover that reimbursement in Medicare
Yeah.
or inpatient rehabilitation centers have been cut, or
Right.
there's this new audit program.
No, it was telegraphed over 3 years. They did.
It was telegraphed over 3 years, and so helping public equity investors understand these changes and make informed decisions, and satisfy their fiduciary duties to their investors. Obviously, you don't want to be investing in stuff you don't fully understand. So that's where the idea and the practice started and really grew up, which is great training, because public equity investors are working on quarter by quarter, and they're working on market movements. Your language has to be very precise, and you have to be able to analyze in a very precise and actionable way what's going on, and you need to be able to say, this is next week, this is next month.
Yeah, the timing is much more critical.
Right.
But I've had great success, and I think other private investors have, in using these same learnings in doing private investments.
Right.
So you just have more time to get your positions in place. It's not as time sensitive, whether it's next week or next month. I'm investing over a 2 to 4 year time horizon, so that's probably okay.
Right, and as the public markets have changed, we call it at JHI the machine, as the machine has, and it's just an algorithm, as it has taken more and more control over the process, those policy moves become more long duration considerations rather than minute to minute, quarter to quarter, which means that it becomes really less valuable, since you're judged on your quarterly earnings. So we started getting, first with you, Vic, getting involved in the private markets, which is more in sync with how policy moves, over years of time, and but using the same precise language and really filtering out all the stuff that isn't relevant, won't happen, you probably don't care about, and focusing on the things where your change is going to be great and it represents an opportunity.
Yeah, and so with all that, talk to me about, I know you have 4 basic, almost like pillars that you see changing in the regulatory landscape. Talk to me about all the change that is sort of queuing up, and I believe this is true no matter who wins the White House. Maybe there's going to be subtle things that happen based on whether it's Trump or Biden, but let's talk about, in general, these things will be true over the next 12, 18, 24 months, no matter what. So what?
And let me talk to first, when we talk about change from the federal government, we're talking about change that is being implemented through the Medicare and Medicaid programs. The willingness of the commercial world to follow along is dependent in part by their interest. And one of the things that we always look at, and hopefully you can see this.
Yeah, it's in kind of a preview mode, but that's fine. Just
yeah. So if you look, one of the things we always consider, and this a starting point really for us, is this insured medical consumer model, which is who's insured by what. Well, with the unemployment where it is, more and more, it's government payers, Medicare and Medicaid.
So it's too hard for me to read. What are the different bars? You have 4 different colors.
Let's see. You've got Medicare at the bottom there.
Okay. Yeah.
And then you have Medicare Advantage. Yeah.
What's the light gray?
That's Medicare Advantage is the next.
Okay. Yeah.
And then followed by employer-sponsored insurance, and then followed by Medicaid.
Okay.
Okay.
It's interesting. So Medicaid is really grow. It looks like it's really growing.
Yeah, and it's going to continue to grow. You know, we've got in the non-expansion states about about 50 basis points of growth month over month.
Yeah.
A little bit higher.
Each month is 50 basis points.
Yeah, it's been growing at about 0.5%. That happened in 08 too, so that's not a big surprise. The non-expansion.
So in general, just in summary, maybe half, around in rough terms, half of the $3.5 trillion is controlled by CMS.
It just went over half.
Okay.
It's never been over half before, and so this is the first time it's gone over half. So the point about is that Medicare law, changes to payment policies really matter because first of all, that's where a lot of people are. Secondly, it is also where the leaders that people look to for leadership. You know, when you're operationalizing a particular function, whether that's joint replacements or open heart surgery, you got to worry about complying with Medicare law, and the penalties are huge. So you operationalize in a lot of cases.
Yeah, so all the other commercial payers, insurance companies, basically, and large employers, they would look to CMS, look to Medicare, Medicaid for guidance because it's such a big and government-sponsored structure.
Yeah, and it provides you with a little cover. Right. They're not supposed to do it, Vic, but they, the trial lawyers will say, oh yeah, they didn't follow Medicare law. Right. But in any event, they're not supposed to. So the four things we're kind of focused on right now, and I'll say that there's more than these four things, but these are four of the most radical things. And one is obviously telehealth. We talk all about, everybody's talking about telehealth. And they're thinking about it as, a patient calling a doctor and getting a prescription. And GoodRx is coming public. Amwell started trading yesterday. Teladoc, of course, is the granddaddy. But in addition to telemedicine, CMS is developing these other pathways, telemedicine as a tool to provide supervision within a health system. So a cardiologist can supervise cardiac therapy, from his office on the main campus of the hospital out to an outpatient clinic, on the edge of town. That's a new.
Yeah. So let's talk about supervision, because to me that is a really critical aspect of these changes, because it goes to the business models and the cost structures and how profitable these businesses can be or how not profitable. So what you're talking about is changing the way that docs are required to supervise medical procedures.
Right. And the big one is during the emergency, the CMS said that the people below the non-physician practitioner. The non-physician practitioner is your physician's assistant, for example, your certified registered
RN.
No, RNs are not. They are below that level.
They're even below that. Okay.
Right. So an RN needs to be supervised directly under normal circumstances by either a physician's assistant or a CRNA or a physician, and same with an LPN. And unless she has other, and she's almost always a she, has other credentials, but we're going to generalize here for a minute. She cannot provide services for that physician unless he provides direct supervision, meaning he has to be in the office suite. So that makes impossible a business model like a group of RNs, doing, you know, doing, follow-up calls from a call center,
Yeah.
unless there's a
Yeah,
physician,
or from their home, or from
or from their home,
wherever.
or,
Yeah, right.
whatever. That is been made, that is going to stay in place until the end of next year. And CMS is asking for comment to make that permanent. So what
So just so I can, because I got confused for a minute, they took away that requirement so that you could have
right.
RNs being supervised over teleconferencing.
Right. So the RN, let's say the RN is in the Philippines, the RN's in the Philippines, and she is tasked with, doing post-surgical follow-up calls.
Yeah.
That's a pretty common thing. The doc can supervise, she doesn't need direct supervision. He doesn't need to be right there. And that allows you to source those nurses for that sort of function really from anywhere, and provided state law and all those other things. But nurses are, really advancing on interstate licensing a lot faster than docs are.
So you can source them from anywhere. There's a shortage, and it's helpful. It also allows one physician to be able to supervise more support, more extenders.
Right, exactly. And that is, that is a productivity boost for healthcare that we really haven't seen in a good while. So that's the big one. And then there are some smaller ones that really facilitate telemedicine within a health system, outpatient therapy, and some other things. So
yeah, so like when I take that as a venture investor, then that opens up a different kind of channel or different place to look at investing in innovations, really like business model innovations.
Yeah.
Where you would have a doc supervising 5, 10, 20 extenders, and they could be delivering services across the country or across the state or across a region,
right,
which would not have been possible before this change.
Right, and I think we've actually even run into companies that were, blocked by those supervision requirements, and so the business model couldn't innovate around it. So
yeah.
So the second area of focus is the site of service. Now this has been underway really since 2015. It really sticks in Congress's craw that you go to the doc for one service, the same service that you go to an ASC for, that you go to an outpatient, and the payment structure is completely different. And so that's been an effort for the last 5 years, but it really has accelerated in the last 2 years. And I mentioned the signaling on the total knee replacement that took place in 2017. Well, they finalized that for 2019, so you can now get your knee replaced in an ASC, and they're adding total hip to that. But what they've proposed this year is not only are we all for moving things out of the hospital setting, but we're thinking about getting rid of this inpatient only list altogether, which isn't even that old. It was 2000 era thing. And so we want to get rid of that whole inpatient only list and let you doctors decide, do you do it in the outpatient department of the hospital, or do you do it inpatient? Because you're grown-ups and you probably know better than we do. Which is a theme, it's a theme.
Yeah. The doctors should use their professional judgment to do it in the safest, most effective patient.
Right, and I think that the answer, they probably do, and then they're blocked, when you have a patient where it's better for them to be outpatient, and we've seen this, during COVID, and then another part of that is, what happens is you have a procedure, it's on the inpatient only list, comes off the inpatient only list, so it can be done inpatient hospital, outpatient hospital. Then it has to be added to the covered procedures list at an ambulatory surgery center. So you could be talking about
so let's just clarify that there's outpatient hospital,
Mhm.
which is different than ambulatory surgery.
Right, ambulatory, so their own animal, and the difference is for an ambulatory surgery center, you absolutely cannot be in that building beyond 23 hours. Okay, outpatient is you're not expected to cross the next midnight or cross a midnight. That means there's latitude in deciding whether you should be held for observation. And
if something happens unexpected,
right,
complication,
they might ship you over to the inpatient part of the hospital. But the ambulatory, the covered procedures, the period of time to get a procedure that was inpatient only available in an ambulatory surgery center was in 5-7 years. And what the administration has done is, first of all, we're proposing to get rid of the inpatient only list. And then the second thing they're proposing is, this whole ambulatory surgery center covered procedure list, what happens is we decide whether something should be added to it based on it being brought to our attention. And people saying, you really need to look at this. And that doesn't really seem fair, because that's really up to practitioners out there to take the time and, visit. So they're talking about changing that. They haven't decided how they're going to change it. One possibility is they're going to have a nominating procedure where people can nominate, different procedures, and you will see Texas doctors nominating everything. They've been very aggressive in the last few years. And the other is to just eliminate all but 3 of the most serious criteria for ambulatory surgery center procedures being kept off the or being put on the covered procedure list. That would allow in 2021 270 new ambulatory surgery procedures to be available in that, assuming the doc wants to do it. Wants to do it there, which is a huge change. And at the same time, CMS has changed the payment structure for ambulatory surgery centers. They used to be paid CPI plus. They used to be paid on CPIU. That would be the inflator CPIU. And they would the CPIU would inflate at a much flatter curve than the market basket for hospitals. And
so hospitals got paid more for the same procedure.
Right, and so you ended up with a big gap like this.
Right.
Okay? So they've changed that, and now it's inflating at the same rate as hospitals. So there's still a gap between them because you started down here, right? But now it's going to rise up, and so now you've got actual incentives.
So what's interesting is that I think both of these things and a bunch of other aspects that the administration is pushing in rulemaking, they're taking away some of the embedded advantages of hospitals and hospital systems.
Oh yeah.
Taking away barriers to entry for people like me to invest in new, innovative approaches, and simultaneously sort of flattening things and allowing more procedures to be done in other sites of care.
Right, exactly. And then
it's kind of bringing competition or bringing all kinds of new approaches.
And as part of that, the price transparency rule is a little fuel on that fire.
So explain that, because that's a huge, I've talked about it, but it's big enough to deserve its own kind of explanation.
Probably. So the price transparency rule, which is, home cooked here in Nashville, is a requirement that hospitals post their prices to all payers beginning January 1. And that's going to be kind of interesting, because we're going to see how it plays out and how much the compliance is. But the idea there is not so much, I believe, that you will go and shop for your knee to be replaced at different hospitals, but that your employer will have some basis for understanding where he can encourage you to go or not go. And the same with your insurance companies, because right now all they know is what they've negotiated. They don't know what that is relative to the market.
Yeah, and maybe compliance will be hard, but there's significant penalties. I mean, they're going to have to.
It's $100,000 penalty, and some of the cynics are saying, well, everybody will just pay it. I never start from non-compliance as a game plan, but that is.
If you're a large employer, you then will be able to see what everything is being billed at. And then obviously that would inform your negotiations.
Yeah, yeah. So you can start with, well, wait a minute, St. Thomas, a knee is
In Nashville, there's three big systems:
right.
Vanderbilt, St. Thomas, and Centennial. St. Thomas is part of Ascension, Centennial is part of HCA, Vanderbilt's, of course, academic medical. They have different prices. And if you're the Nashville city government, big employer,
Right.
you can now see all three and play them against each other. Or just like every market, you have visibility and you can negotiate.
Right. So it'll be crude and not great at first, I suspect, but it will evolve. And I think there's everybody expects things to come out of the government, fully baked, and it's an incremental system, and this is the first building block on what will change.
Yeah. But folks like you and I'm excited to get my hands on it to know, okay, what market should I go open up new things in?
Yeah.
I can see the competitive landscape and be like, oh, we should jump in there where there's no other providers doing this.
Right. Yeah, exactly. So, and then the third area of focus is advancing technology. So the big change there is there's a path at the FDA called breakthrough technologies, and this is you developed a device for which there really isn't an analog already out on the market, and it's going to produce great therapeutic results. So you follow that pathway and you get approved by the FDA. You're immediately approved for reimbursement by Medicare, and that that
has been a really big problem previously to this.
So right. They call it the valley of death. You get approved by the FDA, but CMS won't cover you because they can't establish it's reasonable and necessary unless you go and do all these other clinical trials, and you got to go raise more money, and
it can be years.
Yeah, it can be years. So now, if you get the breakthrough technology designation, you get approved by the FDA, you automatically get reimbursement and can start billing immediately, which means the 70% of devices that never get CMS national coverage determination for Medicare reimbursement, that should collapse to more like or go to more like 95.
Yeah. I view this piece as like streamlining their bureaucracy. Let's get things approved more quickly. Let's get them paid. If they're breakthrough technologies, let's get them reimbursed more quickly. Yeah. And then talk about the interoperability, because that's going to be a big factor, I think, for VCs, like for private investors.
Yeah, that's gonna be a big deal. So the interoperability piece of it, this has been a slog, right? Because you're talking about a system that is just talk about incremental. It's just like an incremental system that's been built, one little piece at a time. Yeah. And so the ONC, which has been charged with all this,
that's the agency.
Yeah, the Office of the National Coordinator for Healthcare IT. They have been working steadily through the rules, and I have to hand it to them. They've been really. They've worked really well with the industry. Many of which have different and competing interests. Epic and Cerner, probably. Right. Less friendly to it than some, and then there are other innovators that aren't as understanding of the privacy issues, that are right. With that. But one of the big things that's I think scheduled to happen this November is that if you go from hospital in Midtown and you want to be admitted to a nursing home downtown, right now you're case spot, your EHR doesn't move. There's no way for those things to talk to each other. Come November, that data has to move. It has to be available to your SNP. And just kind of interesting, giving your information to another entity, but that's what they're going to do. And what'll happen is that all that data will be available in the path that you took. It won't be like a hospital in Minneapolis is ever going to see what happened, but within your community, which is where you will live and be taken care of and stay, that data will be a lot more liquid around the community, and that
it breaks the lock-in, right? Like it used to be that, well, you can go to any skilled nursing facility, but if you leave our network, you're not going to have any of this data that is going to be important to your care.
Right, and
now that lock-in is gone, and you can go wherever you want.
Right, and that also reduces the need for you, the hospital, to acquire certain things, or to be acquired. That's been the big argument for physicians. Oh, we should, we have ethics, so you're not going to be able to see what your patients do at our hospital unless we acquire you. So, and that is absolutely one of the purposes and the intents of the regulation. This administration has been very anti-acquisition, anti-consolidation. They want people to feel free that they can practice independently and not have to be acquired by a large health system. Yeah. So we're gonna see a ton of data movement, and I think business models develop around the availability of that data and innovating with that data so that you can actually produce results, whether that's for employers, whether that's for individual purchasers of health services, or researchers or whatever.
Yeah. So then the fourth I know is around the rural markets, which is a huge change, huge opportunity.
Yeah. Rural is just been, really pretty bad, sad case. We've watched the population, decline, fairly dramatically. Hospitals have closed. We've been left with, really very few options. And this has gotten the attention of the Trump administration, especially since we have seen infant mortality go through the roof. The opioid crisis was a real wake-up call. So there was a memorandum of understanding signed between USDA, HHS, and the Federal Communications Commission. Part of the CARES Act is dedicating a lot of money towards getting providers in these rural areas ready for a broadband environment, being able to communicate to an urban hub, for example, or not even an urban hub. Maybe it's a larger county, a larger town, three counties over, but being able to connect them, first having the infrastructure, but second letting them able to take care of the infrastructure, and specialists on call, SOC, which is going to come public in a SPAC. This is the business they're building. They don't have the concern about the rural versus originating site. They meet those requirements, but they're focused on bringing specialists into rural communities. So I'm expecting
they don't live there anymore. Like many communities don't have specialists.
Right. And what most communities have is still a doctor that can deliver babies, but not always. Not maybe an OBGYN, but an OBGYN as a specialty is what, maybe 100 years old? No, not even that. But OBGYN, has been a real issue. But what they're proposing is maybe you have a midwife, or an RN who can deliver a baby.
But who's there and caring for the mom, caring
right.
for the patient.
But you have somebody on call, a specialist, who can, when you have, the heart problems that a lot of women sometimes exist, postpartum, you have that specialist who can tell you, what to do and when you need to do it. Because so much care, when things go wrong in rural communities, it's almost because somebody didn't recognize what was going wrong and didn't know, what to do to act. And that would help it. But I'm expecting an awful lot of money to get poured into the rural health system or rural health care, in a Trump administration. I'm even expecting it in a Biden administration because it's become a national scandal, the health of rural Americans. So that's and there seems to be a business model there, as SOC demonstrates, but I think that's going to be an area of focus. Not super glamorous for a lot of people, but I think there's some real opportunity to.
Yeah. Okay, so supervision, site of care, advanced technology, and rural are the four big areas. Talk to me about These are Trump administration rules that have been put out. If there's a new administration, do I need to change my whole investment thesis? How much can change? How can we put back in the bottle and what can't be?
Well, really, anything that comes to you via rulemaking is kind of hard to put back in the bottle because it's going to be implemented on January the 1st, 2021. The new president wouldn't take office until January the 20th. Get all his ducks in a row, get his people in place, put out whatever fires need to be put out. You're probably looking at late 2021, when they can really focus on it. Maybe they're particularly good and they can do it earlier, which means any changes that would be made would be 2022. And with price transparency, you're talking about massive investments in infrastructure to make that happen. Do you really say, oh, never mind?
Yeah.
I don't.
A Democrat might say, well, it's already built out there. The information is available. I'm going to go work on something else. I'll go work on access. I mean, they will make their own rules, or they'll do something. But you taught me sometimes they won't go back and fight the old fight.
Yeah, there was only one thing that Joe Biden has indicated that he would change, and that is a Medicaid rule on fiscal accountability. There's money that goes through Medicaid providers through this tax merry-go-round, and the administration, because I think they were trying to divert attention from what they ended up doing, which is saying y'all need to move to value-based care, but they withdrew that, so that's no longer a factor. The one thing I will say, Vic, is price transparency is one area where I expect that there might be a push for modification, not necessarily, ending it, not necessarily, but some modification. And the hospitals.
That's because there's some lobbying group or some.
The hospitals, this administration, when people say he broke Washington, they're not exaggerating. And in breaking Washington, you stop talking to people like the American Hospital Association, and they stop having influence on what you're doing. That's not going to be true of a Biden presidency. He's going to be more open to listening to some of those ideas. So that could mutate. I expect there will be a ton of public blowback if they do. I can see a lot of policy people who have finally gotten their hands on something that they've been wanting for decades, screaming and yelling on Twitter. I think that the site of service will be fine. I think the telehealth will be fine. I would worry a little bit. Maybe the emphasis on rural won't quite be there.
Like the direct supervision via telecom. And I don't know why you go back on that.
Yeah, you wouldn't. And that's something that people forget when they think about presidential changes. There's a whole lot of stuff going on below the surface that isn't partisan at all. In fact, that's most stuff. It's this little stuff up here that gets everybody all worked up.
Yeah, what's interesting as an investor, and for my audience of investors, is that it's billions and trillions of dollars in these changes that we can invest in now. I mean, it's going to happen, and then the presidential politics will do whatever they do. But then a year from now, we'll come back to you and say, okay, now we have the same administration, or we have a new administration. What's been the changes over the last few months?
Right.
And that's why we have to pay you the big money to read through everything. But that's more important than who wins the election, particularly. Yeah. What are all the agencies doing?
Yeah, exactly.
Yeah. Okay. Any final words or things we should be looking for that are more out further on the horizon?
Out further on the horizon, I think there are probably going to be some changes to Medicare Advantage plans. I know the administration is looking at all subsidies. So Medicare Advantage is, of course, a big one. I don't have much more to tell you than that because I don't know. I think that primary care has been a focus. The AMA changed the codes for primary care to make it more focused on time and medical judgment and less, did you do that that exam so we can all stop getting our knee bent every time we go to the doctor. So there's, I think, going to be a continued focus there. I also think that the whole value-based, bundles and all these CMMI programs that emerged out of the Affordable Care Act, they're going to get a pretty good look-see, because they don't all produce results for the government or for patients. So I think those are going to get a pretty good look, but we'll have to see what evolves here.
Yeah. Excellent. Well, Emily, thanks for doing this. I think we have stunned the audience with, there's not a lot of questions, but it's been really helpful for me.
Yeah.
Just for the record, where do people find you online?
Oh, yeah.
What's the website, etc.?
Okay, so you can always email me at eevans@hedgeye, HEDGEYE.com. And hedgeye.com is our website, and just hit me there if you have any questions, or you have any deals you want me to look at, and we love to.
And I'll just say there's a bunch of free content on the site, which is useful, but then when you pay up for the license, it's the whole world opens up to you. And Emily,
that's it. All right, thanks, Vic.
Okay, thanks, Emily. I really appreciate it. Thanks everyone for attending.